Risha, Sanjuta?
Yes, sir.
Okay. So till they get ready to organize, why should you bother about hypertension? What will happen if you don't control the hypertension and take up a patient for surgery?
It can result in
Hmm.
total physiological changes, sir. End organ damage,
Hmm.
even starting from CNS, like the set
Hmm.
point for auto-regulation is altered.
Very good. Hmm.
Everything.
Okay. Hmm. Very good. Okay. Hmm. Intraoperatively, what can happen?
Arrhythmias, sir.
Arrhythmias. Other than arrhythmias, what will be the behavior of the BP? Will it be like a normal person, non-hypertensive, or a patient who has been controlled and taken up for surgery? Will there be any difference in the behavior of the BP intraoperatively?
We can expect a widened pulse pressure.
Hmm. Hmm. How is it described? The behavior of the BP in an uncontrolled hypertensive intraoperatively. Is there any particular terminology for that? Where will be the swing of BP will be very violent, like it will be very high at one time and very low at another time.
Labile BPs.
Labile BP. More than the labile BP, they have given a particular terminology for that. Have you heard of alpine anesthesia? What do people do in the Mount Alps in Switzerland? What sport is very common? Skiing. Skiing. Yeah, it's called skiing, not skiing. Skiing. So where they go down at one time, climb up, and then again come down. So that is what is described as alpine anesthesia. The BP starts with 190, 120, then after induction or after spinal comes down to 80 by 50, and then again you will try to rectify it. It goes up to 170, 100. Then it comes back to 100 by 70. Again, it goes up to 190, 110. Like that, if it is a wild fluctuation, it is called alpine anesthesia compared to the Alps mountains, which have the peaks and valleys. So the same way, the BP also can behave. And that is what is called the alpine anesthesia, which will be very common if blood pressure is not properly controlled. Okay. Right. Dr. Ammu, are you able to hear me? Ammu, are you there? Your name is seen here. Anyway, me or PGs, all of you are able to hear me?
Yes, sir.
Okay, right.
Sir.
Then we'll go on to, and again, like the last class, I asked you, were you all taught in detail about hypertension during your undergraduate days? Like what we asked, I asked you about diabetes, whether it was discussed in detail to have a very good, stable concept about the diabetes. Are you all quite confident in understanding the pathophysiology of hypertension and how to treat a patient if you are going to be the physician for a patient? Let us imagine that your own family member comes with high BP to you. Are you confident of treating them?
No, sir.
Why? So again, these are the basic things what I feel that UG curriculum should concentrate on, because these are more common. Even though in anesthesia we see them, this is also the common morbidities that happen in patients in the general population. So any doctor at the UG level itself should have a very clear concept about both hypertension, diabetes, ischemic heart disease, and obesity or COPD. All these things, a general practitioner should have a very good knowledge so that he can treat the patient confidently. And we should be basically a good physician to become good anesthetist. So with that aim in the mind, let me share the screen and we'll go again. It will be an interactive session, question and answer type of session. So let us check our knowledge and see how we can understand this topic today. Is it visible?
Yes, sir.
Very good. Okay,
Yes, sir.
right. So the topic we are going to discuss today is anesthesia, comorbidity, hypertension. What are the important concepts we have to understand is what is the definitions of hypertension, what are all the various names that are given for types of hypertension, what is the normal physiology to maintain blood pressure in our system, then what is the pathophysiology that happens to cause hypertension in a patient, and what are the anesthetic implications of uncontrolled hypertension to the patient. And lastly, you must know everything in and out about the common medications used. Don't think that it is the prerogative of the physician or the cardiologist to prescribe antihypertensive medications. As an anesthesiologist, you should be also in a sound position with a sound knowledge to control the blood pressure in a patient, which may be happening in the PACU or intensive care unit. So you must have a very clear understanding about the common medications used and their interactions with anesthetic agents or anesthetic techniques. So these are the headings under which we will be discussing this topic today. Now I give you a case scenario. A 70 years old male patient who is posted for resection of a colonic tumor is sent for pre-anesthetic witness to you. His BP recorded is 170-90 millimeters of mercury. How will you proceed to evaluate his blood pressure? This blood pressure alone now. Now the questions, it will be like a question and answer session. So can this patient be branded as hypertensive and treatment started immediately when you see them for the first time in the pre-anesthetic clinic? What is the answer?
No, sir. We can wait for the subsequent readings.
Ah,
Like, we can repeat every 4 hours and say,
hmm. So at the first setting of the blood pressure taken in the pre-anesthetic room, you should not brand any patient as hypertensive. You agree?
Yes, sir.
sir,
Yes. No, a single reading which is high should not be considered as a hypertension. So what is the name given to this hypertension when it is seen on the first time in the clinic?
Hypertension.
Ah, why should it be not considered as hypertension? Because this is called the white coat hypertension. Okay. Now, what is the definition of white coat hypertension? How will you describe or define white coat hypertension? You call it as white coat hypertension because you are seeing the BP to be high in the first occasion. So how will you define? It may be normal after he goes out of the pre-anesthetic checkup clinic, or after the doctor and nurse leave, somebody else in the family takes the BP. It may be normal, isn't it?
yes, sir.
Yes, sir.
So the white coat hypertension is an elevated blood pressure occurring in a patient in hospital or clinic, and recording is done by the doctor or nurse. Otherwise, in other situations, it is quite normal. Okay, so it occurs whenever he comes into the clinic or sees a doctor or nurse coming to take the blood pressure, his blood pressure goes up. What could be the reason for that?
Maybe.
Patient, what happens to the patient when you see a, will anyone be very happy to see a doctor or nurse?
He'll be anxious.
It is mainly due to patient's anxiety. The white coat hypertension is mainly due to patient's anxiety, which causes or triggers a sympathetic system to elevate the blood pressure. Okay. Now, how do you confirm white coat hypertension? When will you say that this is only white coat hypertension, nothing to worry, this is not the troublesome real hypertension? How to confirm that?
After subsequent reading in an interval of 10 minutes, sir.
That is one method. But what is the most scientific method of confirming white coat hypertension?
Measure the BP at home.
Can you measure the BP at a periodic interval at home and then record it in the hospital? And what is the name for that? Have you ever come across a gadget or a technique like that where patient can go home and all the recordings of his blood pressure every hour will be recorded in the hospital, in the monitor, in the computer, and then next day you can get the whole reading, every hour, hourly reading or half hourly reading, both during daytime when he is awake and also during sleeping time in the night. The patient will have a BP cup tied around his arm and he will be sent to the home. He is asked not to remove it until coming back to the hospital next day. And periodically the cuff will get inflated and it will record the BP and send signals to the hospital, and then it will be recorded there. What is that type of BP recording called?
Oscillometer.
It is called the ambulatory BP monitoring. It is also known as the Holter monitoring. A person called Holter, Holter, which is done for both heartbeat and ECG monitoring as well as BP monitoring. Okay, so this is called the Holter monitoring. So it can be confirmed by recording ambulatory blood pressure outside hospital environment, which will show a normal blood pressure all the time. But when she comes into the hospital and it is taken by a doctor or nurse, it will be elevated, and that is what is called white coat hypertension. So the correct definition of white coat hypertension is an elevated blood pressure in the hospital or clinic surroundings, followed by a normal ambulatory blood pressure monitoring. That is the definition of white coat hypertension. So if you don't have this facility of ambulatory blood pressure by tying the blood pressure cuff and sending the patient home, what is the other alternative that you can do? Already you people have answered that question. What you can do? This can be diagnosed by several BP measurements at different times of the day at home. Nowadays, all the people, especially people with a little bit of education and financially sound people, have a auto BP monitor like the Omron, what you use in your hospitals nowadays. Patients also have that and they can check it. Or you can ask the patient to rest for a while in the clinic itself and then let him allow to get used to the hospital environment, and then you can record the BP after say half an hour, 20 minutes. Once he becomes familiar with the surrounding, then the BP will automatically come down. Okay, so this is the method of, so in the case scenario I have given, if the blood pressure is 170/90, which looks quite high, you ask the patient to wait for a few minutes, go through with your other cases, and then ask him to come back again and sit and record the blood pressure. It would have come down. Okay, so that is the method of diagnosing or confirming the presence of white coat hypertension. Now, what other history you need from the patient to evaluate his hypertension? Whenever you find that the patient is having not white coat hypertension but real hypertension. For example, patient himself says, yes, I am a BP patient. I have been taking medication for the last 5 years or 6 years. What other history you should elicit from the patient? First thing, always rule out white coat hypertension in any patient if you are seeing them for the first time, or if the patient already knows that he is hypertensive and he has been on medications or treatment and he has already been diagnosed as a hypertensive patient. What are all the pertinent information that you want to get from the patient?
Sir, when was it diagnosed and the duration of hypertension, sir?
Hypertension, very good. How the hypertension was diagnosed? Is it during routine examination of the patient? Or I think some echoing is happening. Is it during routine examination of the patient for health checkup, for job insurance, or did the patient have any symptoms like frequent headaches, giddiness, or palpitation? Okay, excellent. That is the first question you always ask the patient. Right. What are the next information you want? After you get the answer for this first question, how it was first recognized, what is the next question you want to ask?
Whether he is on regular treatment or not, sir, and
Very
what
good.
are all the medications he is on, sir?
Excellent. What was the BP when the hypertension was diagnosed first time? Was the patient advised medications immediately or advised to do lifestyle modification and come for a review? Okay. So, for example, a patient who had a BP of 140 by 90, should you immediately advise drugs?
Sorry.
Or a patient having 130 by 90 instead of 130 80? As a physician, will you, your own relative comes, say he is only 50 years old, and you check the BP, it is 130 90. Will you immediately say you start taking this antihypertensive medication once a day or twice a day? Will you advise like that?
No, sir.
So, what are the lifestyle modifications you can advise the patient?
Salt restriction,
Salt restriction and smoking.
aerobic
Smoking
exercise.
cessation, very good. Alcohol consumption to be reduced. Okay, regular exercise, avoiding fatty foods, reducing weight if they are on the obese side. Okay, these are all some of the lifestyle modifications that you should advise the patient. Then, what was the medication first prescribed? Did the patient comply with the advice? What was the response to treatment? For example, the very first time you check the BP, it is 160/100. You took repeated readings 2-3 times, still it is 160/100, and you rule out a white coat hypertension, and you decide that patient is a real hypertensive. Then you prescribe them with medications. In that, how soon you should ask the patient to come back? Once you decide a patient is a hypertensive and prescribe medication, at what frequency you should check the blood pressure? What is the guideline for that? Is it dependent on patient's age, or is it dependent on the value of reading?
Initially, after 1 month, then every 3 months once.
Okay, so mostly depends on the age of the patient. If the patient is an young patient, Ammo, if you're recording, please make sure there is no echo. I am getting an echo in the receiver.
He left.
So, are you all getting that echo noise?
Yes, sir.
So you must first do the first checkup after 2 weeks. After the initial prescription of the drug, you ask the patient to take the medication for 15 days, 2 weeks, and then come for a review and see the response. And once stabilized, you can ask them to come for checkup once in 3 months or 6 months, not more frequently than that. What other questions you would like to ask? After the medication, whether they complied with the request, what was the response? The next thing, how frequently patient went for follow-up? Did he follow up at the clinic or did the self-monitoring at home? Nowadays, many people do the monitoring at home itself with the auto BP monitor. So this is a very clear important point. Because why this follow-up by the doctor as well as by the patient himself is important? Will all the patient be able to record their BP correctly using the BP monitor?
No, sir.
No. Sometimes they may not tie the cuff properly. Okay? So there will be an arrow to say that this should be pointing to the artery. There is an echoing again and again. Some problem in recording, I think. So there is a self-monitoring. Patient may have a faulty reading or erroneous reading. So it is always better to counter-check once in a while whether the patient's recordings are correct or not. Then, was there a need for modifying the dose of the drugs or addition of drugs needed during follow-up? So you must always ask how many medications. Some people may take even up to 3 medications. Which type of patients will require more and more medication?
CKD patients.
CKD, excellent. Secondary hypertension because of renal disease, they may have a very resistant blood pressure, which will not respond to a single medication. So the physician might have started with a single medication, then will go on to add a second drug, third drug, fourth drug also may be sometimes needed. So that is where indicative of a very resistant type of hypertension, which is not responding to treatment, which should give you a clue that it is not a simple essential hypertension, it may be a secondary hypertension. So that question is very, very important. Then, are there any symptoms suggestive of target organ dysfunction? Like whether the patient had any anginal feeling, or is he having a frank congestive heart failure, or has he suffered a stroke earlier, or whether there are any features of renal involvement like swelling of the legs or facial puffiness and all these things. Okay, so this information is also very important. And the last question that you should ask, are there any need for emergency admission in the hospital after diagnosis of hypertension when the patient has been taking treatment for that? What type of emergency admission you think it will happen in a known hypertensive who is taking treatment?
Pulmonary edema, stroke, CVA, cerebral vascular accident.
These are all target organ dysfunction. Of course, they can also be emergency, I agree. But with regard to blood pressure reading alone, what type of emergency you will have? Supposing a patient who has been taking, say, amlodipine and for 3 years, suddenly one day his BP, which was all the time 130, 80, starts going up to 150, 100. Within 1 hour, it goes to 170, 120. Another third hour, it goes to 190, 150. And he's having a, it is called accelerated or malignant hypertension. Okay. So that will warrant an emergency admission and immediate control of that blood pressure. Okay. So these are all the questions that you should have. How the hypertension was diagnosed, what was the first BP recorded, was immediately medication started or only lifestyle modifications advised and then later on medication started, what was the medication prescribed, did the patient take it correctly, what was the response to treatment, what was the follow-up like, did he follow it up by himself or went to the doctor, was there any need for adding or discontinuing some drugs? Some patients become hypertensive and feel the effects of hypertension also. Some initial treatment, initially, especially younger patients, if you start with a very high dose, they may feel giddiness because of postural hypotension, and you may have to cut down the medication. So it is not that all the time you will be leaning only to increase the medication, but it may sometimes be working on the reverse also. So this follow for modification of the drug dose is very important. And any target organ, longer the duration. Say some patient says I am hypertensive from my age of 45, and now this patient who has come to us is 70 years old. He has been having hypertension for 25 years. So in such long duration hypertensive patients, you should always look for target organ dysfunction like the cardiovascular system, central nervous system, or renal system, and any emergencies in between, either due to the target organ dysfunction or a rapid increase in the blood pressure, which may be the prodromal stage to producing a CVS calamity. I mean CVA, like central nervous system problem. Okay, so these are the 7 questions, like the 7 wonders of the world, you must remember to ask the patient. Now, what is the definition of hypertension? How do you define hypertension? It is based on the values.
Systolic BP more than 140 millimeters of mercury, and the diastolic BP more than 90 millimeters mercury.
Fantastic. But according to the current guidelines, resting blood pressure more than 130 or more than 80 diastolic. Systolic more than 130. Earlier it was 140/90. What you said is right. But the latest current guidelines says that a resting BP, that means the patient should be in a very relaxed state. More than 130 systolic or more than 80 diastolic is defined as hypertension. What are the types of hypertension? This is a very easy question.
Secondary.
Yes, it is 2 types. Essential, also known as primary hypertension, and secondary hypertension. What factors contribute to cause essential hypertension? Already the answer is there. Factors which contribute are obesity, insulin resistance. This is for essential hypertension, even though we say that it has no cause, primary cause, because primary essential means we don't know why it is happening. So, but the factors which can make a patient suffer from essential hypertension include obesity, insulin resistance, high alcohol intake, high salt intake, aging, sedentary lifestyle, continuous stress, or low potassium intake and low calcium intake. All these things can contribute to essential hypertension. What is secondary hypertension and what are its causes?
Due to any disease,
Underlying systemic disease which is altering the
there is
vascular.
a pathology in some organ which is causing the hypertension. So there is a secondary to a pathology in some organ in the body which is causing the hypertension. So it is called secondary hypertension. And secondary hypertension has a clear etiology. And the causes are renal disease, or it may be usually endocrine diseases like hyperthyroidism, hyperaldosteronism, Cushing's syndrome, and pheochromocytoma, or even obstructive sleep apnea. All these things are the usual causes of secondary hypertension. Now, what are the stages of hypertension? Whenever a patient has branded as hypertensive, we must always stage the hypertension. How do the staging is done?
Elevated hypertension, stage 1 and stage 2 hypertension. Then comes emergency and urgency.
Excellent, excellent. So you have the optimal blood pressure, which is of course much more earlier chart, less than 120/80, elevated 120 to 129, the diastolic which is less than 80 or equal to 80, stage 1 140 to 90, stage 2 is more than 140 and diastolic more than 90, and hypertensive emergencies or urgencies staged as systolic more than 180 and diastolic more than 120. Now, what is spurious hypertension?
A false BP measurement, sir.
False BP measurement by whom? By the doctor or the patient?
It can be due to BP cuff sizes, and also it is based on observer and also the instrumentals.
That is heterogenic, wrong recording. But the word spurious hypertension is used. This is the definition. The term spurious or pseudo hypertension is usually applied to hypertension in old people, elderly individuals, where a brachial cuff blood pressure taken by a non-invasive method is elevated. But if you put an intra-arterial line and measure the blood pressure in that patient, which will be normal. So an elevated BP by non-invasive recording and a normal BP by direct intra-arterial measurement is described as spurious hypertension, and the condition is ascribed to the reason for that is the arteries, brachial artery becomes incompressible by over-calcification. So they always show a high reading when you take it in the non-invasive method. But when you put an arterial line and measure it, it will be normal. So this is called the spurious hypertension. What is isolated systolic hypertension?
Diastolic blood pressure remains within the range.
Normal.
But the systolic blood
Systolic
pressure
alone,
shows
the word itself is self-explanatory, isn't it? Only
Yes,
the
sir.
systolic blood pressure is elevated, but the diastolic will be within normal limits.
Normal.
So there will be a wide pulse pressure. That is the essential hypertension has many different forms, one of which is called isolated systolic hypertension. The most common form of hypertension in older adults, in which systolic pressure is elevated with a normal diastolic blood pressure. Earlier, they used to advise that you don't have to treat this isolated systolic hypertension because it is a age-related factor. As you have the answer in the previous question, it is due to the incompressibility of the vessel wall. So they said that isolated systolic hypertension need not be treated. But current opinion is if it is more than 180, the normal diastolic of 80, you have to treat the isolated systolic blood pressure also, because in the long run it will produce cardiac effects. Now, what are the National Institute for Health and Care Excellence, that is NICE guidelines for diagnosing and follow-up of hypertension in adults? So the UK, there is a National Institute for Health and Care Excellence for recommendations for diagnosing and follow-up of hypertension in adults. And this is the chart. When the blood pressure is under 140/90, which is the clinic BP, check the BP at least every 5 years, and more than that if you close to 140/90, especially younger people. And the home blood pressure management or ambulatory blood pressure monitoring, under it should be 135/85. Then check BP at least every 5 years, and more than that if the BP close to 140/90. If evidence of target organ damage is already seen, consider alternative causes. That is, rule out secondary hypertension all the time. But if the BP is between 140/90 and 179 and 119, that is close to 180/120, offer ambulatory or home blood pressure monitoring, investigate for target organ damage, assess the cardiovascular risk, and then if it is exceeding 180/120, which is the crisis stage as we saw in the earlier staging, assess for target organ damage as soon as possible, consider starting drug treatment immediately without ambulatory or home measure management. Repeat clinic BP every 7 days if no target organ damage is present, and refer for specialist opinion whenever there is for the presence of any retinal hemorrhage, papilledema, which can be indicative of accelerated hypertension, or if there are threatening systems and suspected pheochromocytoma in all patients with a PP of more than 180, 120, always keep in the back of your mind the possibility of a pheochromocytoma. And at the home level, these are the various readings. And if the age is less than 40 years, first offer lifestyle advice, and if not possible, go for drug treatment. Consider specialist evaluation, secondary causes, and assessment of long-term benefits and risks to be taken care of. And in between the according to the age, you have to go for all these guidelines and advices. So this is the chart which is available in all the books that you can follow. Now comes the second part of this. After the definition of hypertension and the various types of hypertension, we should know something about the normal physiology of blood pressure regulation. Okay, so how is the blood pressure regulated in our body? What is the mechanism? First of all, how is blood pressure produced in the body? What are the factors contributing to the blood pressure?
It is the pressure exerted by the column of blood moving against the wall of blood vessels.
Lateral pressure exerted by the blood on the walls of the blood vessels. That is the simple definition to say what is blood pressure. But what are the contributing factors to blood pressure? What are the cardiovascular contributions to the blood pressure? What components of the cardiovascular function contribute to
Systolic
Preload,
contraction.
contractility, afterload.
The blood pressure is equal to stroke volume into peripheral resistance. Okay, that is the simple calculation of blood pressure. BP is equal to stroke volume multiplied by peripheral vascular surface. So the physiology of blood pressure regulation consists of a delicate balance by nervous system and hormonal control to maintain arterial pressure at near normal. So the control of blood pressure is by both the nervous system and by the hormonal system. So which nervous system is responsible and which hormonal system is responsible for normal blood pressure to be maintained?
Renin-angiotensin, aldosterone.
That is hormonal, isn't it? Renin-angiotensin, aldosterone, RASS is RAAS is hormonal control. But what about the nervous control?
Baroreceptor.
Baroreceptor, very good. So baroreceptor control is very, very important. And what is the difference between the two?
So one acts immediately. Baroreceptor action is immediate, and hormonal is on the long run.
Long run, very good. So excellent. So what is the importance of mean arterial blood pressure? We know there is a systolic blood pressure. We know there is a diastolic blood pressure. But majority of the time, we always aim to maintain a mean arterial pressure of, say, above 60 millimeters of mercury. In auto-regulation, we have to maintain a MAP of between 60 to perfusion. Excellent. So how do you calculate the mean arterial pressure?
1/3 of the
diastolic blood pressure plus 1/3 of pulse pressure.
Pulse pressure, excellent. So that is the simplest formula which you can remember. Diastolic blood pressure plus 1/3 of the difference between the systolic and diastolic, which is called the pulse pressure. 1/3 of that is equal to. So if a patient has a normal blood pressure of 120 by 80, what should be his mean arterial pressure?
80.
93.3.
92.
Doctors, I think you are all very slow in mathematics. Okay, 80 plus 40 divided by 3, which is 13.3. So 93.3 will be the mean arterial pressure. So this mean arterial pressure is the steady state component of blood pressure and is crucial as the body regulates proper perfusion pressures to vital organs at this pressure, and also it optimizes the cardiovascular work. So the two things which are dependent on mean arterial pressure are perfusion of the various organs and also the cardiac workload. Both are dependent on mean arterial pressure. What are the two mechanisms of blood pressure control? We have already seen the answer is there again at the top. So one is the baroreceptor mechanism regulated by fast neurally mediated baroreceptor mechanism and a slower hormonally regulated renin-angiotensin aldosterone mechanism. Where is the vasomotor center and what is its importance in control of blood pressure?
In the carotid sinus.
Vasomotor center. Carotid sinus is the peripheral. That is where the baroreceptor reflexes are emerging from. That's the peripheral location.
It
The
is in the
question is
medulla.
vasomotor. Medulla and pons. Simply, that is the answer. Vasomotor center is located in the reticular substance of the medulla, the lower third of the pons, and responsible for providing both sympathetic and parasympathetic outflow to effector organs. Okay, this is what will get affected. If there is a raised intracranial pressure and the brain tends to go through the foramen magnum, the brainstem will get compressed at the foramen magnum, and that is where the vasomotor center is situated. So the coning will cause cardiorespiratory arrest because both the vasomotor center and respiratory centers are situated in the medulla and pons. So when that small portion of the brain tries to go through the foramen magnum and gets compressed, patient usually dies of cardiorespiratory arrest because of this reason. Remember that point, then you will never forget. So it is the reticular substance of the medulla and lower third of the pons which are controlling both the sympathetic and parasympathetic supply to the heart and blood vessels. So this center transmits sympathetic impulses to the spinal cord and peripheral sympathetic nerves to all the arteries, arterioles and veins in the body, as well as parasympathetic impulse through vagus nerve to the heart also. And through this powerful influence of sympathetic outflow, the body can regulate vascular vasoconstriction and heart rate to maintain normal blood pressure values. So that is the role of this vasomotor center. What is the most powerful autonomic regulator of blood pressure? Again, this has been already answered, and you should be able to tell the answer.
Baroreceptors.
This is the most powerful autonomic nervous sympathetic mechanism for regulating the blood pressure is baroreceptor reflex. Okay, remember that point. How is the baroreceptor reflex activated? What is the triggering factor for the baroreceptor reflex to become active?
A change in
Increase
blood
in
pressure.
heart rates.
Change in blood pressure is usually picked up.
Change in blood pressure.
When the blood pressure increases, what will happen to the arterial, the vessel wall? Will it get stretched or will it get compressed?
It gets compressed.
Compressed.
There's
See,
a
you are
direct-
trying to inflate the tire of your two-wheeler or your car. You keep on putting more and more air. What will happen to the tire? It will bulge out or it will shrink?
It bulges out.
Bulge out. Same thing, no? Whenever the pressure increases in the vessel, it has to stretch the vessel. Okay? So the stretch receptor, the baroreceptor reflex is initiated by stretch receptors within the two portions. One is in the aortic arch, the other is in the carotid bodies. Where is the carotid body situated? Aortic arch, you can say it is the arch of the aorta. After it has emerged from the left ventricle, it goes like a C, upside down C. That is the arch of the aorta. But where is the carotid body?
Between between internal carotid and external carotid arteries.
Bifurcation of the carotid arteries. The bifurcation on both the carotid artery, the common carotid, which bifurcates into internal and external, that is where these carotid bodies are situated. So the aortic arch is a very close to proximity to the heart. The carotid bodies are after the arch of the aorta gives off the innominate from the first branch, and the common carotid, left common carotid as the third branch. They go up and then divide into internal and external. So the innominate becomes the subclavian and right common carotid. Then there is a left common carotid. Then there is a left subclavian. These are the three branches arising from the arch of aorta, if you remember your basic anatomy. So that internal the common carotid which bifurcates, at the bifurcation you have these carotid bodies. These two are the sensors for the stretching of the vessels, stretch receptors, and they give feedback signals to the central nervous system for a minute-to-minute regulation of your blood pressure. This is how your blood pressure is kept in a constant level without much of fluctuation by this particular reflex. So what is the role played by the carotid sinus and the aortic arch receptors? Is there any difference in their mode of signaling, or both of them just do the same function? Why nature has given these two different receptors?
Carotid sinus is usually a stretch type of receptor.
Both are stretch receptors. See, here it is given, it's a reflex initiated by stretch receptors within aortic arch and carotid bodies. The answer is here already in this sentence. So both are stretch receptors only. But is there any difference in their functional status? The answer for that is this. The baroreceptor sinus near the bifurcation of common carotid arteries are more sensitive to decreasing arterial pressure. So whenever there is a hypotension, this sinus will give the answer, because it is not adequately stretched. It will stimulate to correct that hypotension and increase the blood pressure. Whereas the baroreceptors, which are in the aortic arch, which are very close to the heart, they are sensitive to increasing blood pressure. So imagine whenever the left ventricle is pumping the cardiac output, we just now saw that blood pressure is stroke volume multiplied by peripheral systemic vascular resistance, SV into SVR, stroke volume into systemic vascular resistance. So when the blood comes out from the left ventricle and gets pushed into the arch of aorta, that is the first level of the vasculature which it will encounter. So here the nature has made it so sensitive that whenever if the pressure is increasing, that should be immediately transmitted to the central nervous system to reduce it, so that you don't get damaged or you don't get the ill effects of high pressure. But once the blood passes through the branching from the aorta and goes to the common carotid, it tends to become lower and lower, isn't it? Initial force will be very high, but as the blood travels down the vasculature, the blood is going to get lose its pressure, momentum, and decrease in pressure. So nature has made it in such a way that the common carotid bifurcation carotid bodies, they have to sense any lowering of blood pressure below a normal limit and immediately send a signal to restore that. So how beautifully nature is working to prevent a hypertension happening very close to the heart and a hypotension happening distant to the heart. So the carotid bodies sense the lowering of blood pressure, whereas the aortic arch receptors sense the increase in blood pressure. So that is how the balancing is done to maintain the blood pressure in a normal way. Now, how is the parasympathetic system activated and conveyed to the heart? Of course, we have seen it already, but we have seen it. It is the vasomotor center which is supplying the parasympathetic system. So how it is activated is, again, the baroreceptor reflex signals the nucleus tractus solitarius in the medullary portion of the brainstem. These baroreceptor signals inhibit the vasoconstrictor center in the medulla and excite the vagal center, which stimulates parasympathetic activity via the glossopharyngeal nerve from the carotid sinus receptors and the vagus nerve from the receptors in the aortic arch also. So the carotid sinus parasympathetic is via the glossopharyngeal nerve. Aortic arch parasympathetic supply is through the vagus nerve. So there are two different nerves activated through both the carotid sinus and aortic arch to do the reduction in the heart rate and blood pressure if the blood pressure goes up. So the result of activation of parasympathetic system will be, it will predominantly decrease the heart rate and the strength of contraction and cause vasodilatation of veins and arterioles. This will always try to reduce the blood pressure whenever there is a increase in the blood pressure. So that is why in a patient with a predominant parasympathetic tone, they always have a very low heart rate. Have you heard of Boris Becker? Any idea who Boris Becker was?
No, sir.
He was a German tennis player, 7 times champion in the tennis Grand Slams. So his heart rate was only 40 because he was such an athletic person. He can play tennis for 5 hours, 6 hours without getting tired. So Boris Becker's heart rate in those days, they said it is between 35 to 40. This is called vagotonic individuals. So in those people who have a vagotonic nature, whenever you administer regional anesthesia, you have to be very, very careful because they cannot increase their heart rate to compensate for any fall in BP or reduction in BP. Okay? So this is the main important function of parasympathetic system. Now, why the baroreceptor reflex is crucial? Because as we already saw the answer, the baroreceptor is crucial in maintaining relatively constant blood pressure, which I mentioned in the earlier answer as a minute-to-minute control of the blood pressure. Despite positional changes, that is, you may be lying down, suddenly you may get up. At the time, there should not be any fall. Or such when a person stands up after lying down or other activities which increase blood pressure, such as eating or exercise. So it should not allow the BP to go up unduly or reduce unduly to cause any disturbance. So that is the main function of the baroreceptor reflex. So it maintains the blood pressure at a very constant level. Now comes the slower control. What is the role of renin, angiotensin, aldosterone system in BP control? When will renin come into play? And what is the complete cycle of this renin, angiotensin, aldosterone system? Where is renin produced from? What is renin and where is it produced?
Renal juxtamedullary system.
Very good. Juxtaglomerular apparatus produces the renin. What is renin? Is it a carbohydrate or a protein or a fat?
Protein.
Protein, sir.
It's a peptide. Protein. It's a form of protein. It's called peptide. Okay. So when will this renin be stimulated or produced? Where is it produced from? Is it directly produced from the juxtaglomerular apparatus?
It is stored in the vesicles, sir. So whenever there is
Vesicles.
decreased,
It's stored in
renin
vesicles in
molecules.
juxtaglomerular apparatus or it is in released from somewhere else. Juxtaglomerular apparatus is a sensor to stimulate the release of renin. It doesn't store renin as it is. Renin is released from the endothelial cells of the afferent arterioles of the glomerulus. Okay. So the juxtaglomerular apparatus, whenever there is a fall in the afferent arteriolar pressure, or whenever there is a decrease in sodium level in the blood that is coming to the afferent arteriole, that will be sensed by the cells of the juxtaglomerular apparatus, and immediately it will trigger the release of renin, which is a peptide stored in the afferent arterioles of the glomerulus, and that will enter the bloodstream. And where will that renin go? Will it be able to
liver,
immediately
to lung, to
to the lung?
liver,
To the lung?
liver,
Huh?
liver first, and then
It will first go to the liver. And what is present in the liver? Which one will be activated by the renin in the liver?
angiotensinogen converting
Angiotensinogen to
Angiotensinogen.
Converting
Okay, another peptide called angiotensinogen will be activated by the renin, and this angiotensinogen will be converted to
angiotensinogen 1.
Angiotensinogen, which will be converted to angiotensin 1 by the renin in the liver. Okay, there is a substrate called angiotensinogen. Renin, which is released by the afferent arteriole glomeruli, will enter the bloodstream, go to the liver, cleave the angiotensinogen and make it into angiotensin 1. This angiotensin 1 will have to go through again to the bloodstream. Where will it go?
The lung.
Into the pulmonary vasculature. Okay? Everything goes into the bloodstream only. Nothing comes out of the bloodstream. So it goes into the pulmonary vasculature, where there is an enzyme called angiotensin converting enzyme.
enzyme.
So the angiotensin 1 is converted again into angiotensin 2. And this angiotensin 2 is the most powerful vasoconstrictor, which will increase the blood pressure whenever there is a drop in blood pressure. This happens, so you can imagine the baroreceptor, which is the fast acting, immediately senses the stretching or the decrease in stretch, and immediately sends signals and rectifies. So it is called the fast method of control of blood pressure. Whereas here it has to go through the renin angiotensin aldosterone system, has got several steps to go through. It has to be released by the endothelium. It has to go to the liver, then convert angiotensinogen into angiotensin 1. From there, that peptide has to go to the pulmonary vasculature, get converted to angiotensin 2, and then come and act on the entire system of the vasculature. So that is why it is a slow process of control of blood pressure. Okay. So renin angiotensin aldosterone system is part of the powerful feedback system for long-term control of arterial pressure as well as volume homeostasis. So what factors stimulate the renin angiotensin system? Already I told you the answer. Stimulated by reduced cardiac output, decreased renal perfusion, hypovolemia, or decreased sodium intake. So two factors, either the decrease in pressure or volume or decreased sodium will stimulate the so what antihypertensive drugs can act on this or a particular renin angiotensin aldosterone system. So once you know how this system is activated, you can block the action at various levels. So can you name a few drugs which act on this system to reduce the blood pressure?
AC inhibitors and
AC
ARBs.
inhibitors, ARBs, very good. And aldosterone is also stimulated in this cycle. What is the role of aldosterone? Antagonist. Okay, right. This picture will tell you how the whole thing can happen. So the site of medication action on renin angiotensin aldosterone system, when there is a reduced cardiac output or decreased renal perfusion, hypovolemia, decreased sodium intake, what happens? The angiotensinogen is converted to angiotensin by the renin. So if you block the release of this renin, there are drugs called renin inhibitors, which will prevent the conversion of the active component of angiotensin 1 from angiotensinogen. That can block the blood pressure. Beta blockers also indirectly depress this renin activity. So they can also to some extent prevent the conversion of angiotensinogen to angiotensin 1. And the main AC inhibitors, they prevent the conversion of angiotensin 1 to 2 at the pulmonary vasculature level. So they can also reduce the blood pressure. But once angiotensin 2 is formed, then it will act on the angiotensin receptors. So you can block it at that level. And it will also stimulate aldosterone. So if you use aldosterone antagonists after they are produced, that also can reduce the blood pressure. And calcium channel blockers, they go on to decrease the vascular tone and then cause a sympathetic nervous system activity, and then they go to beta blockers. Indirectly, all these things can affect these points. But you can remember these 4 drugs. One is beta blockers, renin inhibitors, AC inhibitors, and ARBs. These are the 4 drugs which directly have an effect on the renin angiotensin, and also aldosterone antagonists can be included to that. Right? Now, after having learnt about the normal physiology of blood pressure, we have to know why hypertension happens, or what is the pathophysiology of hypertension. Now, so far, have you understood how the normal blood pressure is maintained and what are the reflex mechanisms involved? Is it clear? Yeah.
Yes, sir.
Now we'll go to the pathophysiology of hypertension. What is the role of cardiac output and peripheral resistance? Or you can specifically say stroke volume and peripheral resistance in the maintenance of blood pressure. That you can say maintenance of not is dependent on the balance between cardiac output and peripheral vascular resistance. Whenever there is a drop in cardiac output, what will happen to the peripheral resistance?
Increase in the resistance.
Increase in the resistance, and vice versa. Whenever there is a increase in peripheral resistance, cardiac output will decrease. Okay, so this is what will happen. So most patients with essential hypertension have a normal cardiac output, but a slightly raised peripheral resistance. This is the first pathophysiology that you have to understand. So in the early stages of essential hypertension, which we have been thinking that there is no reason at all, or primary hypertension, there is no cause. That is what we have been taught all these years. But extensive studies have found out that people who develop essential hypertension, if you do an echo, their ejection fraction will be normal. But if you calculate the peripheral resistance in them, there is a raised peripheral resistance. This is the first problem that happens in them. Now, which vessels are responsible for causing the peripheral resistance increase?
Arterioles.
Arterioles, very good. So it is not the large arteries or the capillaries, but the small arterioles, the walls of which contain smooth muscle cells. Okay, so that is the reason why the arterioles are the, just like in the lung, if you compare, it is the bronchiole which has got the smooth muscle which goes into bronchospasm. The other things are all cartilaginous. Upper airway, generation 1 to 19, they are all cartilaginous. So whichever part of the body has got some muscle to contract, that only can alter its diameter. So that is why the small arterioles which have the smooth muscle, they are responsible for the peripheral resistance. What causes the contraction of these smooth muscles? What is the mechanism by which these smooth muscles contract? Normally, what is the mechanism for any muscle to contract? Which ion is responsible?
Sodium channel and calcium channels.
Sodium channel is mainly to the striated muscles.
Okay.
Voluntary muscles, not smooth muscles. Contraction of smooth muscle is thought to be due to rise in intracellular calcium concentration, which may explain the vasodilatory effects of drugs like calcium channel blockers. So when you use calcium channel blockers like nifedipine, amlodipine, they prevent the entry of calcium into the smooth muscle cells. That is how they are able to keep them in a relaxed state and reduce the blood pressure by causing vasodilation. So the important ion which is responsible for contraction of smooth muscle is calcium. And what causes irreversible increase? So initially, the peripheral resistance increases in essential hypertension with a normal cardiac output or stroke volume. But as the hypertension, when it is not treated, it goes on to become, the peripheral resistance goes on to become irreversible. And what is the reason for that is prolonged smooth muscle contraction is thought to induce structural changes with thickening of the arterial vessel walls, possibly mediated by angiotensin, leading to irreversible rise in peripheral resistance. This is how the essential hypertension happens. Initially, it starts as a reversible peripheral resistance, but if not detected properly and not treated properly, this increase in peripheral resistance goes on increasing. That is why there is a commission for joint commission for treatment of hypertension, which suggested that patients should be treated only with calcium channel blockers as a first line in the earlier commission. Before that, it was beta blockers. So Joint National Commission 6, 7, every 2 years they publish their guidelines. In the earlier guideline, it was beta blocker, which is considered as the first line of therapy. But later they changed it to calcium channel blockers because of this particular fact that you should produce decrease in peripheral resistance, which is the main mechanism for the increase in the blood pressure. But now what is the guideline? Which drug you should start?
So if it is less than 55 years, we'll go with ACE-ARB inhibitors and beta blockers.
Yes.
If it is
Only
more than
patients
55
who
years,
are calcium channel blocker. Excellent, excellent. So this is the guideline. Less than 55, go for ACE or ARBs. More than 55, calcium channel blockers. Okay. So what changes happen to cardiac output and peripheral resistance in the early and late stages of hypertension? This is another pathophysiology you have to know. So in very early hypertension, peripheral resistance is not raised to that level, and elevation of blood pressure is caused by a raised cardiac output, which is related to sympathetic overactivity. Earlier I said it is the raised peripheral resistance, but when the person starts to have a tendency to go for hypertension, it is the elevated cardiac output due to sympathetic activity. Normally it is a sympathetic tone increase which causes that. But subsequent rise in peripheral arterial resistance might therefore develop as a compensatory manner to prevent the raised pressure being transmitted to the capillary bed, where it would substantially affect self homeostasis. So this is the very early stage. It is the raised cardiac output, but within a few days of this raised cardiac output due to sympathetic activity, peripheral resistance starts to compensate. That is how the peripheral resistance start increasing, and initially it is a reversible peripheral resistance. Later on it becomes irreversible because of the constant pressure and change in the structure of the arteriolar vessel wall, resulting in permanent essential hypertension. Is it clear? This is how the pathophysiology of hypertension happens with regard to cardiac output and peripheral resistance. Now, does the renin-angiotensin system have any effect or any role in the production of hypertension? The circulating renin-angiotensin system initially was not thought to be directly responsible for the rise in blood pressure. But many hypertensive patients, they have found that there is a low level of renin. You can assess the blood renin level by taking a blood sample, as well as you can assess the angiotensin 2, which is the final vasoconstrictor substance. So when they analyzed that, they found it was in fact very low in those patients, and the drugs which were given to block them were not very effective in these patients. So that is how they found out that it doesn't have a direct responsibility. But later on, what happens, there is a non-circulating local renin-angiotensin epicrine or paracrine systems which also controls the blood pressure, and the local renin systems have been reported in the kidney, heart and arterial tree, and they have important roles in regulating regional blood flow. So initially it was thought it is only the kidney which produces that, but the recent investigations have proved that there are local renin systems in the heart and arterial tree itself. Now, what is the role of autonomic nervous system in hypertension? Does autonomic nervous system have a role? Supposing a patient is a very anxious patient, all the time worrying, very stressed out, which system will cause hypertension in those patients? When you are stressed or when you are worried or when you are anxious, which hormone is stimulated in your body?
Catecholamines.
Catecholamines. So there is evidence suggests that epinephrine and norepinephrine have a clear role in the etiology of very little evidence is there, but it is probable that hypertension is related to an interaction between autonomic nervous system and the renin-angiotensin system, because the sympathetic stimulation can directly stimulate renin production. Okay, and other factors like including sodium, circulating volume, and described hormones have all been postulated as the cause for hypertension. What is the role of vascular endothelium that is responsible for causing hypertension? Now, vascular endothelial cells play a very important role because they produce two molecules. One is called nitric oxide, which is a vasodilator. Another is a vasoconstrictor peptide called endothelin. This should be in good balance. Whenever there is a vasodilation needed, nitric oxide should be produced. Whenever there is a vasoconstriction needed, endothelin should be produced. So this is a very, very important function of the vascular endothelium to keep the peripheral resistance in constant state all the time by balancing the production of nitric oxide and vasoconstrictor. Now, if this function goes into aberrance, it doesn't function properly, there is always a increased production of endothelin which causes vasoconstriction. That has been postulated. These are all theories which are given for causage of essential hypertension, because secondary hypertension we know exactly which organ is at fault, but for essential hypertension all these years we were telling there is no reason how it is happening. Now one by one they are postulating these are all the possible mechanisms by which the essential hypertension is happening in patients. So we have seen sympathetic stimulation, we have seen renin-angiotensin to some extent, and we have seen vascular endothelial dysfunction. In the last class when we discussed about diabetes, there also we found that ultimately it is the vascular endothelium which is causing all the problem, like increased production of superoxide and antioxidants and all those things. So similarly here also it is the imbalance between the nitric oxide and endothelin production which may be responsible for essential hypertension. Now clinically effective antihypertensive therapy appears to restore impaired production of nitric oxide but does not seem to restore the impaired endothelium dependent vascular relaxation or vascular response to endothelial agonist, and this indicates that endothelial dysfunction is primary and becomes irreversible over once the hypertensive process has become established. So this is the theory that is being done. Apart from these substances, there are some more vasoactive substances in causing hypertension. So let us see one by one. Many vasoactive substances which affect sodium transport and vascular tone are involved in the maintenance of normal blood pressure, and However, the part played by them is not still clear. It is in the still being investigated. Now, one such substance is bradykinin, which is a potent vasodilator that is inactivated by angiotensin converting enzyme. So, one method by which AC inhibitor works is it prevents the conversion of angiotensin 1 to 2, which is the angiotensin 2 is the powerful vasoconstrictor. So, that production is decreased. Another mechanism, it doesn't break down the bradykinin, and bradykinin by itself is a good vasodilator. So that also adds to the vasodilator property. So the mechanism by which AC inhibitor causes a decrease in blood pressure is both by preventing the conversion of angiotensin 1 to 2 and also not breaking down the bradykinin, which is the vasodilator. So if AC enzyme, angiotensin converting enzyme is going to act normal way, it will convert the angiotensin 1 to angiotensin 2 and also break down the bradykinin. But in the usage of inhibitors for that enzyme, bradykinin will accumulate. And what is the other unwanted side effect of this accumulation of bradykinin, which is considered as a side effect of
Angioneurotic edema.
angioneurotic edema?
Cough,
Side effects of
irretractable cough.
Cough, sir.
cough. So the cough is caused by the bradykinin. So consequently, AC inhibitors may exert some of their effects by blocking bradykinin inactivation also. Then the next vasoactive substance, endothelin, is a powerful vascular endothelial vasoconstrictor which may produce salt-sensitive rise in blood pressure. It also activates local renin-angiotensin systems. So this is the second vasoactive substance apart from bradykinin. Then there are endothelial derived factor, namely it was originally called EDRF but later identified as nitric oxide, produced by arterial and venous endothelium, diffuses through the vessel wall into smooth muscles causing vasodilatation. So any defect in the production of nitric oxide, that also is likely to cause a constant vasoconstriction instead of vasodilatation, resulting in hypertension. Then atrial natriuretic peptide is a hormone secreted by the atria of the heart in response to increase in blood volume. So its effect is to increase the sodium and water excretion. So it causes natriuresis. That is, natri means sodium, uresis means passing urine. So it causes loss of both sodium and water excretion from the kidney as a natural diuretic. So any defect in the atrial natriuretic peptide production and its function, that also can lead to fluid retention and hypertension. And sodium transport across vascular smooth muscle also thought to influence blood pressure and interfere with the calcium transport. There is another molecule called obein, which may be naturally occurring steroid-like substance, which will interfere with sodium and calcium transport, giving rise to vasoconstriction. So these are all some of the postulations or theories about the vasoactive substances: bradykinin, endothelin, absence of nitric oxide, atrial natriuretic peptide, and defect in sodium transport caused by the alteration in the transport mechanism or presence of a naturally occurring steroid-like substance called obein. So these are all the various theories that have been postulated for the presence of essential hypertension. Now, what is hypercoagulability concept as a cause of target organ? Once we know that if you don't treat an hypertension properly, more than the increase in blood pressure, it is ultimately the damage to the various organs that causes more problem than the blood pressure itself. So it can affect the central brain in the form of CVA, or it can affect the heart in the form of left ventricular hypertrophy, coronary artery problem. It can affect the kidney in the form of renal damage, or it can affect the retina. These are the 4 organs which are mainly targeted. So there is how these organs are affected. And there is a theory called hypercoagulability theory. Any idea about this? So this is supposed to be the reason for the target organ dysfunction in hypertension, which says patients with hypertension demonstrate abnormalities of the vessel wall. As we saw earlier, endothelium gets dysfunction or damage, and the blood constituents like platelet activation, fibrinolysis, or hemostatic factors, all these things become abnormal, and the blood flow, rheology and viscosity and flow reserve are also affected, suggesting that hypertension confers a prothrombotic or hypercoagulable state. So there will be miniature clots that are formed in the various organs, which will reduce the vascularity of the organ and make that organ become dysfunctional. Okay, this is called the hypercoagulability concept because of the damage occurring in the vessel wall, the blood constitution, as well as the flow physiology. So these components appear to be related to target organ damage and long-term prognosis, and some may be altered by So if you start antihypertensive therapy, the early stage of detection of hypertension, these changes can be prevented. So that is the reason why we need to treat hypertension as quickly as possible. Now, what is the Birmingham paradox, also known as thrombotic paradox of hypertension? This is the answer available in the earlier question itself. Whenever there is an increase in pressure in a vessel wall, it is stretching the vessel wall. So what do you expect to happen to the vessel wall? Supposing a person's BP is 220, 140. What will happen to the stretching of the vessel wall? It will become stretched too much, or it will not get stretched too much? Hello? Anyone of you are there?
Yes, sir. Yes, sir.
Whenever the pressure increases, stretching will it increase? Supposing you keep on inflating your car tire more than 35
Yes,
psi, what will happen? Your tire can burst, or it will remain same?
Burst at one point.
So similarly, you expect the vessel to rupture and produce a hemorrhage, isn't it, when the pressure increases? But on the contrary, what happens? Although blood vessels are exposed to high pressures in hypertension, the main complication of hypertension, like stroke or myocardial infarction, is paradoxically thrombotic rather than hemorrhagic. That is what is called the Birmingham paradox. So for some reason, the vessels don't rupture that easily, but they develop a clot. So they become thrombotic rather than hemorrhagic. That is called the thrombotic paradox. Now, how is insulin sensitivity related to hypertension? This is another mechanism. All diabetics over a period of time gradually will become hypertensive also. You would have come across many diabetics, even if they start with diabetes, they become hypertensive over a period of time. So how does insulin sensitivity affect hypertension? There is a clustering of several factors like obesity, hypertension, glucose intolerance, diabetes mellitus, and hyperlipidemia. So this has led to the suggestion that these represent a single syndrome, which is also called the metabolic syndrome X or driven syndrome, with final common pathway to cause raised blood pressure and vascular damage. There are many objections to this hypothesis, but it may explain why the hazards of cardiovascular risk are synergistic or multiplicative rather than just additive. So what is the role of genetic factors in causation of hypertension? Supposing the parents are hypertensive, is there a chance that the offsprings also will develop hypertension? Although separate genes and genetic factors have been linked to the development of essential hypertension, multiple genes are most likely to contribute the development of disorder in a particular individual. So Hypertension is about twice as common in subjects who have one or two hypertensive patients, and many epidemiological studies suggest that genetic factors account for approximately 30% of the patients. So if the parents are hypertensive, you have to keep a watch. The children also are likely to develop hypertension. And lastly, any intrauterine fetal factors which can result in hypertension in adult life. Definitely, which fetal factor will be the cause for hypertension in adulthood? Low birth weight. There is an increasing evidence that fetal influences, like particularly birth weight, may have a determinant blood pressure in adult life. So babies who are small for their age also more likely to have metabolic abnormalities and later develop hypertension and cardiovascular disease and all the other things like insulin resistance, diabetes mellitus, hyperlipidemia, and abdominal obesity. This is called Barker hypothesis. So low birth weight, if a baby is born as a low birth weight baby, you have to keep a watch. And insulin resistance almost certainly contributes to the increase in the prevalence of coronary disease seen in adults of low birth weight. Now, how does diastolic dysfunction occur in hypertensive patients and what is its effect on cardiac function? If a person is not treated properly for hypertension, over a period of time, he will develop diastolic dysfunction also. What is the reason for that? What will happen to the musculature of the left ventricle?
Hypertrophy, concentric hypertrophy will be there in
Concentric hypertrophy. So once the muscle becomes hypertrophy, it tries to contract more effectively to push the blood against the peripheral resistance or systemic vascular resistance. That is how the muscular hypertrophy occurs. Once the muscle becomes hypertrophied, will it be able to dilate or relax as much as it is in the normal shape?
No, sir.
It cannot.
So the filling time is reduced.
So hypertensive left ventricular hypertrophy, the left ventricle cannot relax normally in diastole. Thus, to produce necessary increase in ventricular input, especially during exercise, there is an increase in left atrial pressure rather than normal reduction in left ventricular pressure, which usually should produce a suction effect. Only when the ventricles dilate and create a little lower pressure, it can suck the blood from the higher pressure of the left atrium. So that cannot happen if the muscle hypertrophies. So this can lead to increase in pulmonary capillary pressure that is sufficient to induce pulmonary congestion. So the rise in atrial pressure can also lead to atrial fibrillation. That is the effect of the LVH that is happening. And in hypertrophied ventricles dependent on atrial systole, the loss of atrial transport, that or the atrial kick, which normally happens by atrial contraction, which will be lost in atrial fibrillation because the muscles of the atrium are not contracting its force, they are just fibrillating, resulting in significant reduction in stroke volume and pulmonary edema can happen. So exercise-induced subendocardial ischemia also can happen, which will exaggerate the impaired diastolic relaxation of the hypertrophied myocardium. So the left ventricular hypertrophy is the main culprit which causes the diastolic dysfunction or inadequate relaxation. This will lead to rise in left atrial pressure. The left atrial pressure increase will result in atrial fibrillation, and it will also get transmitted to the pulmonary circulation, leading to pulmonary edema if a patient with LVH goes on straining. So if your patient shows evidence of LVH in the ECG, intraoperatively, if the patient's heart rate or the pressure increases, then you can land up in a pulmonary edema because of the changes that have already occurred because of the diastolic dysfunction. So always look at the echo of the patient where they will mention diastolic dysfunction grade 1, grade 2, grade 3. If it is mentioned as grade 3, there is a very severe impairment in the relaxation of the ventricular musculature. So you have to be very, very careful in fluid loading the patient as well as in maintaining the heart rate and peripheral resistance or blood pressure. That is the moral that you have to learn. Now, what are the mechanisms of end organ damage in uncontrolled hypertension? Already we have seen one reason, the thrombotic nature. Anything else you are aware of?
The set point for autoregulation is altered, and
so first for that we have to know what are the changes that happen in the vasculature. Okay, the molecular and mechanical factors. There is an increase in angiotensin II, oxidative stress, vascular endothelial growth factor is increased, tumor necrosis factor alpha is increased, and platelet derived growth factor is increased, thrombin levels are increased, shear stress is happening, stretch is happening, cell injury happening. These are all the molecular and mechanical factors which affect the endothelial cells, vascular smooth muscle cells, and endothelial membranes also. So there is a effect of this. These are the vessel components which are affected, which causes the alteration, impaired relaxation, inflammation, angiogenesis, apoptosis in the endocardial cells, endothelial cells. Then the vascular smooth muscles, they hypertrophy, there is a cytokine production and the migration and proliferation of vascular smooth muscle, which will cause thickening and stiffening of the vessel, and the matrix regulation, collagen formation is increased. All of them will result in atherosclerosis, vasculopathy, and hypertension. This is the basic change in the vasculature triggered by all these factors. That is the main reason for the organ damage. And once the changes happen, the arterial stiffness that happens along with the endothelial dysfunction can affect the various organs. It can cause the ischemic heart disease, diastolic heart failure, atrial fibrillation, systolic heart failure, all these changes in the heart. It can affect the kidney in the form of chronic kidney disease. It can affect the brain in the form of stroke, especially thrombotic stroke, and increased sympathetic activity. So all these things are the results of hypertension. So first thing to happen is the vascular change, and because of the vascularity changes, remember this point, arterial stiffness, which is going to affect the various organs. Okay. Now comes what is malignant hypertension. This is also a very important pathological state which can result in an emergency situation for patient with hypertension. How do you define malignant hypertension? Right, malignant hypertension term used to
markedly
describe
elevated hypertension with papilledema.
Papilledema. So it is a elevated blood pressure with multiple complications of end organ damage with a poor prognosis. And the term usually is reserved for patients who have a systolic BP of more than 180 and a diastolic BP of more than 120. Okay, this is the limit. It should be more than these two factors. So what are the causes of malignant hypertension, which is also called as hypertensive crisis? What will cause malignant hypertension? There are multiple causes. One, patient is not taking medications properly, medication non-compliance. They neglect it. In spite of the fact that BP is always high, they don't take the medication properly, they can land up in this problem. Or if they have already developed a renovascular disease or already having a renal artery stenosis, polyarteritis nodosa, Takayasu arteritis, these people are likely to develop this. Then renal parenchymal diseases including glomerulonephritis, tubulointerstitial nephritis, systemic sclerosis, or endocrine dysfunctions like phaeophromatocytoma, Cushing's, primary aldosteronism. That is all secondary hypertension patients are more likely to develop this. Coarctation of aorta patients or drug exposures including cocaine, pencyclidine, sympathomimetic, erythropoietin, which is given as a treatment for correcting the anemia in renal CKD patients. That itself can trigger malignant hypertension. And cyclosporine, which is given as an immunosuppressant, all that has got that cause. And antihypertensive medication withdrawal. Can you tell me the name of one drug which is notorious for this?
Beta blockers.
Beta blockers can cause myocardial ischemia more than malignant hypertension. Clonidine is notorious for rebound hypertension, which is once you withdraw the drug or stop the drug abruptly, they will have what is called rebound hypertension, which can result in severe hypertension. And amphetamines, which are taken as a recreational drugs, they also are known for that. And central nervous system disorders such as head injury, cerebral infarction, and cerebral hemorrhage are all the causes of malignant hypertension. What is the pathognomonic feature of malignant hypertension? When should you call? Supposing patient has got a BP of 200 by 140, then can it be called as malignant hypertension?
With the impending end organ damage, we call it as malignant.
Pathognomonic feature means it should be objective.
Oh, papilledema.
Papilledema, excellent. So to make a diagnosis of malignant hypertension, papilledema has to be present. So you must do a retinal study, must do the fundoscope and see for the presence of papilledema. If papilledema is present, then only it is called malignant hypertension, and BP should be automatically very much elevated. So what is hypertensive urgency and what is hypertensive emergency?
Urgency is elevated blood pressure.
Emergency is without end organ damage, and urgency is with end organ damage.
Emergency is with end organ damage.
Emergency
And
means
urgency
there
is
is
with
a
impending
threat to the
organ
life.
damage.
Then only you call it as emergency. Urgency means you have time. It is still not life-threatening. Okay, hypertensive emergency is life-threatening. Urgency is still not that life-threatening. So hypertensive urgency is severe hypertension without end organ damage. As hypertensive emergency is severe elevation which is associated with end organ damage and requires immediate treatment. That is emergency. Okay. What are the investigations needed to evaluate a hypertensive patient? Normally,
Sir,
what are the investigations?
Renal parameters, urea, creatinine.
Creatinine, very good. So you must investigate for all the target organ functions. Simply, if you remember that, you will be able to ask for all the relevant investigations, isn't it? You can ask for investigations which are going to affect the heart. You can ask for investigations for the kidney, okay, retina. So ECG, chest X-ray, urine analysis, electrolytes and creatinine, cardiac biomarkers if there is an acute coronary syndrome, toxicology screen, CT, MRI of the brain, and there is head injury or neurological symptoms, hypertensive retinopathy, nausea, vomiting, contrast studies, and transthoracic echo. If aortic dissection is suspected, you can go for all that. So what is the treatment? How do you treat an hypertensive emergency? Because it is life-threatening, you have to control the blood pressure. So how do you treat it? Can you just give oral tablets and wait?
Oh, sir, injection forms can be started.
You have to go for parenteral treatment. Okay. So it is not recommended to the BP to be reduced too fast or too much. So don't aim for a patient admitted to 220, 150 blood pressure. Don't try to bring it to 140, 90 in the next 1 hour. So it has to be done very gradually, just like not reducing the blood sugar in a diabetic ketoacidosis very rapidly. You should not reduce the blood pressure also very rapidly because patient's autoregulation is shifted to a higher level. So if you reduce the blood pressure too rapidly, this autoregulation cannot get adjusted, and patients organs, especially brain, will become ischemic. And even if he has not developed a stroke, he will produce a iatrogenic stroke by reducing the blood pressure faster. So ischemic changes can occur in vascular territories that have become habituated to the elevated level of blood pressure. So for most hypertensive emergencies, mean arterial pressure should be reduced by approximately 10 to 20% within the first hour, and by another 5 to 15% in the next 24 hours. So in the first hour, you must reduce only the mean arterial pressure from 10 to 20%. Then over the period of next 24 hours, so it requires admission to an intensive care unit, and you must adjust the dosage of the drugs in such a way that first hour you reduce the mean arterial pressure. Don't look at the systolic or diastolic. Look at the MAP, because that is the perfusion pressure for the organs, and try to reduce the blood pressure accordingly. Now, common intravenous medications and doses used to treat hypertension emergencies include. Can you name some of the drugs?
Labetalol,
Labetalol, very good. Nicardipine is available as infusion rate at 5 milligram per hour, increasing by 2.5 milligram per hour every 5 minutes to maximum. Because nicardipine is a what category of drug?
calcium channel inhibitor.
Calcium channel blocker. So this will reduce the peripheral resistance. So this is recommended as the first line of drug, which will, this is the dosage. So maximum 15 milligram per hour, nicardipine is available as an IV preparation. The next drug you can use is sodium nitroprusside. The dose of 0.3 to 0.5 microgram per kg per minute. And you can increase, if the response is low, you can increase it to 0.5 microgram per kg per minute every few minutes as needed, to a maximum of 10 microgram per kg per minute. What is the mode of action of nitroprusside? SNP. Which part of the vasculature is responsible for vasoconstriction or vasodilatation? Which we saw as arteriole. So this is an arteriolar dilator. Okay. SNP is a predominantly arteriolar dilator. Arterioles only have smooth muscles. We saw in the earlier slide. So it should dilate the arteriole. So it is an arteriolar dilator. And next thing is labetalol, which can be given in dose of 10 to 20 milligram IV, followed by bolus of 20 to 80 milligram at 10-minute intervals until the target blood pressure is reached. The maximum you can give is 300 milligram for a period of 24 hours. And what is the advantage of labetalol? And what is the other disadvantage of sodium nitroprusside? It is a wonderful arteriolar dilator. It will bring down the BP immediately. But what will happen to the heart rate when you use sodium nitroprusside?
Tachycardia.
There will be reflex tachycardia. Okay. So if the patient already has a compromised coronary circulation, this reflex tachycardia can precipitate an acute myocardial infarction. That is the disadvantage. Second thing is, second important complication of SNP. Exam, they keep this drug in the Viva and ask you all these questions.
Can raise the intracranial pressure.
Can raise the intracranial pressure. So, okay. But by drug's nature.
Methemoglobin. Methemoglobin.
Yes, it is notorious for tachyphylaxis. After the first few minutes of wonderful reduction in BP, you will find the drug is requiring more and more doses. That is called tachyphylaxis, reduced response to repeated doses. That is known as tachyphylaxis. So this drug is notorious for tachyphylaxis. So if you go on increasing the dose to achieve the same desired effect, you will end up with cyanide poisoning. The sodium nitroprusside will become cyanide and affect the mitochondria and produce histotoxic anoxia. So Cyanide toxicity is another life-threatening complication of sodium nitroprusside usage. Reflex tachycardia, worsening the coronary perfusion, and the production of tachyphylaxis, resulting in the need for increasing the dose and resulting ultimately in cyanide toxicity. And another thing is, it is a drug which should not be exposed to light. It will get degraded. So it requires specific bottles which are silver foil covered, and also the infusion sets. So this is a hazard. So that's why this is not very commonly used. And labetalol, apart from alpha blocking effect, what is the advantage?
It also
Is
blocks.
it primarily
blocks the
alpha? It is a alpha and beta blocker. Okay. So which particular condition you use labetalol as a preferred agent? Which
Pregnancy
induced pregnancy induced hypertension. Excellent. And last drug is esmolol. It is the initial dose of 500 microgram per kg over 1 minute. Now, what are the exceptions where you should not reduce the BP so rapidly? Which particular conditions, if supposing already some target organ dysfunction has occurred because of malignant hypertension,
Hemorrhage, brain hemorrhage.
Acute phase of ischemic CVA. Okay, BP is not usually treated unless it is greater than 185, 110. In those who are pre-perfusion therapy could be an option, or greater than 220 by 120 in patients who do not qualify for reperfusion therapy. So this is ischemic cerebrovascular accident. Then supposing there is a myocardial ischemia, will you reduce the BP? Acute aortic dissection.
No,
That's also you should not do. Intracerebral hemorrhage and acute myocardial ischemia. Okay, so these are the 4 conditions. Just hold on, I'll come back. Okay, sorry. Are you able to hear me now?
Yes, sir.
Am I audible?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Hello?
Sir?
Am I audible, ma'am? No, I am not getting.
Yes, sir.
யாருக்கும் ஒன்றும் ரெஸ்பான்ஸே இல்லை, அதனால தான்.
We could hear, sir.
ஓகே ஓகே, எனக்கு அப்போ என்னோட ஹெட்ஃபோன் ஏதோ ப்ராப்ளமா கேட்குறேன். ஓகே, தேங்க்யூ. Can some of you respond now? And just
Sir,
check.
we can hear, sir.
Are we audible, sir? Sir?
Sir?
Sir?
கேக்குதா?
கேக்குதுங்க sir.
Okay, now I'm also able to hear you. Right. So these are the 4 conditions where you should not reduce the BP like treating a malignant hypertension. One is the cerebrovascular accident, aortic dissection, intracerebral hemorrhage, and acute myocardial ischemia. And what are the mechanisms by which the antihypertensive drugs work? So that can be easily understood once you know how the blood pressure is maintained, normal blood pressure, and then you can select what are all the ways the various drugs are acting. So the stroke volume or cardiac output multiplied by the vascular resistance is the method of blood pressure maintenance. Cardiac output is maintained on by contractility, heart rate, and preload. Vascular resistance is by arterial or venous vasodilation, and the CNS, heart, kidneys, renin-angiotensin aldosterone system, and vascular smooth muscle. These are all the important considerations which are maintaining these 2 important components of blood pressure. So for the CNS, you can use centrally acting drugs. For the heart, you can use beta blockers. For the kidneys, you can use diuretic. And beta blockers also can act on the renin-angiotensin system, as we saw in the earlier slide. They can reduce the production of renin itself. Anti-renin activity is there. And you can use AC inhibitors, which prevent the conversion of angiotensin 1 to angiotensin 2. And you can use calcium channel blockers, which act on the vascular smooth muscle mainly. And some of them have rate controlling effect on the heart also. And you can use alpha blockers, which are direct vasodilators, and you can use vasodilating drugs. So these are all the various drugs that are used and their mechanism of action. Now, how do you classify the antihypertensive drugs? Is there any way you can classify the antihypertensive drugs?
Arteriodilators, venodilators.
Arteriodilator and venodilator. No. Divided into 2 broad groups. First group is directly or indirectly blocking the renin-angiotensin system. Examples are AC inhibitors, angiotensin receptor blockers, direct renin inhibitors, and to a lesser extent beta blockers. Okay, so these are the drugs which are acting on the RAS system. The second group of drugs work by increasing water and sodium excretion, thereby reducing intravascular volume or causing vasodilatation through non-RAS pathways like calcium channel blockers. Okay, so this is how you classify drugs acting on the RAS system and non-RAS system pathways. That is how you can classify the antihypertensive medications. So the examples of the second group are diuretics and calcium channel blockers. Now, what is a nice recommendation to start antihypertensive therapy, which already I think Risha answered? Patients under the age of 55 to be initiated on drugs which target the RAS as the first line therapy, namely the AC inhibitors or ARBs or ARAs. And patients aged over 55 or black people of African and Caribbean family initially treated with drugs acting through non-RAS mechanism, especially low renin hypertension. So what are the sites of drugs acting on the RAS, which we already saw? It can be already four areas which we saw. One is antagonistic to renin, then AC inhibitors, ARBs, and to this you can also add the aldosterone antagonist. So these are the four drugs acting on the RAS system, and beta blockers have a very indirect action of renin antagonism. They decrease the production of renin itself. Now, what are the drugs therapy recommended and goals of treatment of hypertension? For this, there is a chart given by the NICE again. So, patients with diabetes, without diabetes. So, you can classify those without diabetes only hypertensive, age less than 55, age 55 and above or over, and the race. These are the three categories. Are patients who are already diabetic as well as hypertensive. These are the two categories of patients you should first do. For the step 1, always start with AC inhibitors or ARBs. And for patients above 55, as we saw in the earlier slide, start with calcium channel blocker. Step 2, you go for AC inhibitors, ARBs, plus if the pressure is not controlled, go for calcium channel blocker or thiazide like diuretic. And here you can reverse, you can start or add these two drugs if they are not controlled with the calcium channel blockers alone. And step 3 is all the three together. So depending upon the blood pressure, so the step 4 to confirm the resistant hypertension comes from elevated BP with ambulatory blood pressure monitoring or phone blood pressure monitoring. Check for postural hypertension, and then you can use low dose spironolactone. After all these things, if they fail, that is ACE or ARB plus calcium channel blocker plus thiazide diuretic, then add spironolactone as the fourth drug. And alpha blocker or beta blocker if blood pressure is more than, potassium is more than 4.5. Potassium is the guideline value for starting on spironolactone or alpha and beta blocker. Seek expert advice if BP is uncontrolled or optimal tolerated doses of 4 drugs. If the patient is not getting controlled with 4 drugs, then you have to go for a specialist consultation and think of other methods of controlling the blood pressure. For monitoring the treatment, use clinic BP to monitor treatment. Measure the standing and sitting BP in people with type 2 diabetes or symptoms of postural hypertension, or patients who are more than 80 years old. Advise people to buy a self-monitoring machine and ask them to monitor at home. Then BP target, reduce and maintain BP at the following targets. For less than 80 years, ideal BP, clinic BP should be 140/90 and home BP should be 135/85. For more than 80 years old, you can allow BP to be 150/90 in the clinic setting and 145/85 at home setting. And patients who develop postural hypertension, base target and standing BP should be accordingly allowed to be slightly high. And if the patient has frailty or multimorbidity, use clinical judgment for deciding the target of the blood pressure. Now, what is masked hypertension and what is its significance? Have you heard of this word, masked hypertension? Okay, masked hypertension is almost like the reverse of white coat hypertension, where it is defined as normal blood pressure in the clinic, but when the BP taken at home is always elevated. Ambulatory BP or home BP is more than 185/95, less than 135/85, but in the clinic it is always slightly high. Whereas in the white coat hypertension, in the clinic it is elevated, at home it is normal. So if you, the reverse of that is called masked hypertension. It is not diagnosed by routine medical examination, but carries an adverse prognosis both in terms of increased target organ damage and cardiovascular events. So it is always better to ask the patient to record the blood pressure at home and bring you the values both morning and evening. And if you find it consistently elevated, and when you check the BP and it is normal, don't just leave the patient, start treating them, giving them start them antihypertensives, because their home BP is always higher. I mean, sorry, don't treat them because the BP is high in the clinic, because their ambulatory BP is normal. So they don't require any, I mean, you have to start them on small doses of antihypertensive, because even though it appears to be normal in the clinic, it may be higher at the home. So if the BP is high at home, you have to always have to treat them with the drug. What are the indications for use of ACE other than the treatment of hypertension? Do you use angiotensin converting enzyme inhibitors in any condition other than treatment of hypertension?
Heart failures.
Very good. They are indicated in heart failure, post myocardial infarction, diabetic nephropathy, and chronic kidney disease. So in all these cases, there is a role for, because it's supposed to remodel the heart muscles. So that is the reason why you can give it in heart failure, post myocardial infarction, diabetic nephropathy, and kidney disease. What led to the development of synthetic orally acting? How did they find out that there is a drug which can inhibit or deactivate the angiotensin converting enzyme? From which source they found out that this drug is available, or this drug can be used to treat hypertension? Just like a quiz question. There's nothing to do. You don't know, that doesn't matter. So the discovery that the venom of Brazilian pit viper, which causes a massive decrease in arterial pressure by inhibition of angiotensin converting enzyme, led to the development of synthetic orally administered angiotensin converting enzyme inhibitor. This is the Brazilian pit viper, and the zoological name is Bothropas jararaca. Okay, so this is the viper from whose venom they found out that there is a molecule which inhibits the ACE. So what is angiotensin converting enzyme and its action? What is the normal role of ACE in the body? All of you know it converts. It is a metallopeptidase enzyme. It is a protein, but it has a metal component, zinc in it there, which occurs mainly within the pulmonary vasculature. It cleaves the peptide hormone angiotensin 1 to angiotensin 2 and metabolizes the peptide bradykinin to inactivate substances. So it acts on both angiotensin 1 and bradykinin. But the angiotensin converting enzyme inhibitor blocks only the conversion of angiotensin to angiotensin 2. So there is a accumulation of bradykinin, which is normally broken down by ACE. That is the reason for the distressing cough that is produced by that. And what is the mode of action and side effect of ACE inhibitors and how they are caused? Mode of action, already we know that it causes the suppression or deactivates the enzyme. So reduction in angiotensin 2 is responsible for the antihypertensive effects of ACE inhibitors. But the accumulation of bradykinin has some therapeutic disadvantage through vasodilatation, but it is also partly responsible for the hypotensive effect, and it also causes the dry cough in susceptible individuals. They can also precipitate renal dysfunction by decreasing renal efferent arteriolar tone, not the afferent arteriole, but the efferent arterial tone, thereby decreasing effective renal perfusion, a particular risk in renal artery stenosis. So if the patient has a renal artery stenosis, in which case it will be termed as secondary hypertension, you should not give AC inhibitors. Now the important contraindications. So young patients coming with a very high BP always look for a renal artery stenosis. How can you detect renal artery stenosis? What investigation will help you to detect renal artery stenosis?
Ultrasound and CT.
Ultrasound.
Doppler.
Renal artery Doppler study.
Doppler.
Okay, very good. Renal artery Doppler study will definitely help you to identify renal artery stenosis. So other side effects are hyperkalemia due to reduced aldosterone secretion. So aldosterone is very important for elimination of potassium. So that is also suppressed. So you will have hyperkalemia. Sometimes you can get agranulocytosis, skin rashes, and taste disturbance. These are all the unwanted side effects of ACE. And a very rare idiosyncratic reaction is angioedema, and because of that, potential upper airway obstruction. And this need not happen with the first dose. It can happen after several years of treatment also. So you have to be very watchful. If any patient gets the angioneuritic edema, what is the treatment?
Since it is not involving mast cells, just wait and watch.
The patient, by the time if he goes for airway obstruction, he will be in trouble. So that is a homework question. You try. There is an antidote for this, but normally we give steroids, isn't it? For any angioneuritic edema, we give antihistamines and steroids. But here they won't work. Drug is to be used for this angioneuritic edema produced by AC. There is a specific drug. Okay, you tell me in the next class. And they are contraindicated in pregnancy as they can cause organogenesis problem. So birth defects can happen. So pregnant patients should not receive ACE inhibitors. What is the mode of administration of ACE? They are orally administered, but there is a IV preparation also. It is called enalaprilat. Okay, so this is the bottle which contains 2.5 milligram in 2 ml. So it is 1.25 milligram per ml, which can be used for IV. What is the peculiar nature of first generation? So AC inhibitors are called first generation, second generation based on the time with which they were all marketed, produced and marketed. So the peculiarity of first generation AC inhibitors, can you just tell me? They were all prodrugs. Okay, enalapril, ramipril, perindopril are all prodrugs which require hepatic conversion to active form. Can you tell me any other prodrug as an analgesic? Again, another question to answer next week. What is the advantage of second generation ACE? Captopril is an active drug converted to active metabolites by the liver. So it is a straight drug. It need not be converted. It is not a prodrug. It is a drug active by itself, and the metabolites are also active. So that is the advantage of second generation. Lisinopril, which is an active drug, but it is excreted unchanged in the kidney. So they are excreted mainly by the kidney. So in patients with renal damage, you have to avoid them. Better in CKD patients, better to avoid ACE because or you have to give it in a very titrated, careful dosage. So what are the drug interactions of ACE? Which drugs you should not administer when the patient is on ACE inhibitors? They interact with NSAIDs, especially nowadays, your tendency is to give the diclofenac as an infusion form during surgery. Major surgeries, you give paracetamol, diclofenac, everything as a part of non-opioid regime for analgesia, isn't it? So better be careful in giving diclofenac or even paracetamol for that matter. When you use ACE, the patient is on heavy doses of ACE, which can result in renal dysfunction. They can also reduce the efficacy of ACE because they decrease prostaglandin synthesis. And interactions with diuretics may cause hypovolemia and hyponatremia. And use of potassium supplements or potassium-bearing diuretics like spironolactone may result in hyperkalemia. And drugs which are renally excreted, like digoxin and lithium, may accumulate in patients taking ACEs. Why it is advised to withhold ACE before anesthesia? This is a very common question asked in the examination. All of you should be able to answer this. Normally, when the patient...
we can expect a refractory hypotension.
Hypotension, fantastic. There is an increased risk of hypotension on induction of anesthesia in patients who have recently taken ACI, which may necessitate the use of vasopressor drugs in order to restore arterial pressure. Okay, so that is the problem. What are the advantages of angiotensin receptor antagonists? We have seen 4 classes of drugs: direct renin inhibitors, ACEs or ARBs, and of course remotely aldosterone inhibitors as well as beta blockers. What are the advantages of using these drugs? ARS, that is angiotensin receptor blockers, they do not inhibit bradykinin metabolism, so therefore the cough is not there with, as you see with ACE. And the therapeutic and side effects are broadly similar to ACEs, with evidence of reduced risk of new onset diabetes or stroke or progression to cardiac failure. And all-cause mortality with chronic kidney disease is almost equal, either ARB or ACE. The risk of angioedema is very much reduced with angiotensin receptor blockers or antagonists, whichever way you want to call. You can call ARB or ARA. So that edema problem is not there. What is the mode of action of this angiotensin ARBs or ARAs? ACE, we saw that it blocks the conversion of angiotensin 1 to angiotensin 2. But here, angiotensin receptor blocker. So, angiotensin 2 production is normal, but the action of angiotensin 2 is blocked by blocking the receptor. They are orally administered drugs which target angiotensin 1 G protein coupled receptors to antagonize the effect of peptide hormone angiotensin 2. So it does not reduce the level of angiotensin 2, but it only blocks the action of angiotensin 2 by blocking the receptor where it has to go and get united. So the drugs which are used are candicertran and telmisartan, which bind irreversibly, whereas the losartan and valsartan, which are later generation of ARBs, they act as a competitive antagonist. Okay, so there is a small difference between these varieties of ARBs. The telmisartan and candicertan, they bind to the receptor in an irreversible manner until the drug is available in the, you cannot dissipate that. Whereas the losartan and valsartan, they compete with the angiotensin 2 and produce the effect. And direct targeting of angiotensin receptors has the theoretical advantage over AC inhibition. So angiotensin 2 may be produced through non-ACE pathways also. So previously it was thought only in the pulmonary vasculature this conversion is going on and that is produced, but the enzyme kinase in kidney tissue is also able to produce angiotensin 2. which is not affected by angiotensin converting enzyme inhibitor. So that is how ARBs, angiotensin receptor blocker, scores over the angiotensin converting enzyme because there is an extra pulmonary route, just like the extra hepatic metabolism of certain drugs. There is an extra pulmonary production of ACE in the kidney, which is not affected by angiotensin converting enzyme inhibitor. They block only the enzyme in the pulmonary vasculature, not at the other sites. So is it necessary to withhold angiotensin ARBs before anesthesia? You
Yes,
said
sir.
you will withhold ACE. Should the same thing be practiced for ARBs also?
Yes, sir.
Yes. They are also at the increased risk of hypertension after induction, particularly when in combination with diuretics. So hence better to withhold them. Now there is a new category of drug called direct renin inhibitor available. What is the advantage and disadvantage? Have you ever heard of the name of this drug? Direct renin inhibitor. There is a drug called aliskiren.
Yes, sir.
Aliskiren. Okay, a piperidine derivative. It is the only available drug in this class. What other piperidine derivative we are using in anesthesia?
Hypertension.
Hmm? Okay, another homework for you. It is used by specialists in patients who are unresponsive or intolerant to other antihypertensives. Aliskiren directly inhibits the enzyme renin, which is secreted by granular cells of the juxtaglomerular apparatus. Of course, it is wrong. It is secreted or stimulated by the granular cells and secreted by the vascular endothelium. Renin inhibition reduces the conversion of hepatically secreted polypeptide angiotensinogen to angiotensin 1, and the effect is on the RAS system upstream of ACE inhibitor. That is, even before the angiotensin 1 is produced, it is blocked. So it does not cause bradykinin accumulation again. And direct renin inhibitors have the same potential to cause renal dysfunction and electrolyte disturbance, just like ACEs and ARBs. And diarrhea is a specific side effect to higher doses of DRIs. What is the pharmacokinetics of DRI? It is they are orally administered. Although they are poorly absorbed, bioavailability is low. Therefore, therapeutic plasma concentration is only achieved by repeated dosing. So once a day dosage is not enough. You have to give in multiple doses. It is metabolized. The main route of elimination is through the hepatic route, not like the kidney by the other drugs which we saw. Therefore, it has a long elimination half-life. What are the conditions other than hypertension in which beta blockers are used? Where else we use beta blockers apart from treatment of hypertension?
Sir, arrhythmias,
Angina,
tachycardia.
heart failure, some rhythm
Hyperthyroid.
disturbance.
Hyperthyroidism we use, very good. Used for
Anxiety.
migraine
Anxiety.
headache, we can use for tremors, okay, we are used as a first line antihypertensive unless there are other indications. They are not used as a first line, but it can be used in tachyarrhythmias. They are also used in stable heart failure, thyrotoxicosis, esophageal varices, anxiety and glaucoma, as well as migraine and tremors. Non-selective beta blockers can be used, propranolol. What is the mode of action of beta blockers? All of you know, it is antagonizes the catecholamines at beta adrenoreceptors. These G stimulatory type of G protein coupled receptors are classified as beta 1, predominantly present in the heart and kidneys, and beta 2 present in the lungs, blood vessels, and muscle. So block of beta 1 receptors result in sinoatrial node reduces heart rate, block of myocardial receptors reduces the contractility. So it produces both decrease in chronotropy as well as inotropy. And they also reduce the sympathetic nervous system activity while blocking receptors in the juxtaglomerular apparatus, reduces renin secretion. How can you classify beta blockers?
Cardioselective, non-selective, and alpha
Fantastic.
blocker, beta blocker. Alpha blocker.
Beta blockers, cardioselectivity, metoprolol, esmolol, atenolol have greater affinity for beta 1 receptor than beta 2. So they are called cardioselective drugs. Non-selective drugs are propranolol and sotalol, which act on both beta 1 and beta 2. So most beta blockers are pure antagonists. However, some drugs have partial antagonism at beta receptor and exhibit some agonistic or sympathomimetic activity like pindolol and timolol. So they can increase the heart rate. Some beta blockers like propranolol and metoprolol block sodium channels and have membrane stabilizing activity. So they come under the antiarrhythmic agents also. Von Wagner classification of class 1 drugs. And labetalol is a beta blocker which also has some amount of alpha blocking activity. What are the advantages and disadvantages of beta blocker usage? Beta blockers improve myocardial oxygen supply demand ratio and help to reduce myocardial ischemia by prolonging the period of diastole. So coronary perfusion is better augmented in beta blocker therapy. They have a potential to worsen symptoms in some patients by reducing cardiac output. So it's a double-edged weapon. So if the patient is in heart failure with a low ejection fraction, you should avoid beta blocker. But a patient with a preserved ejection fraction, you can use a beta blocker so that it will reduce the oxygen demand by the myocardial cells. And poor peripheral circulation and Raynaud's phenomena may be precipitated if there is a reduced cardiac output when you use beta blockers. Bronchospasm caused by beta 2 blockade can be significant in patients with asthma. And central nervous system effects like malaise, tiredness, and vivid dreams, especially with propranolol, can happen. And insulin-dependent diabetic patients may not feel the symptoms of hypoglycemia like tachycardia, sweating. All this may be suppressed by the sympathetic blockade. So they can quietly slip into hypoglycemia. So which beta blockers are available for IV use and what is the difference in their duration of action? Can you name the beta blockers which are available as IV preparation, which you might be using in your OT regularly?
Esmolol, metoprolol.
Metoprolol, very good. So IV preparations are available for atenolol, metoprolol, propranolol, and esmolol. These 4 are available. And the lipid-soluble drugs like metoprolol and propranolol are metabolized by liver and have a shorter half-life than water-soluble drugs like atenolol, which are excreted largely unchanged in the urine. But one exception here is esmolol. How is esmolol metabolized? By the tissue esterases. So how is the difference? Is metabolized by ester hydrolysis by the tissue esterases, and it has a rapid offset of action. So you can titrate it much easily compared to using metoprolol and propranolol, which have a longer duration of action. So any acute control like intubation stress response, you always go for esmolol and not metoprolol or propranolol. Okay. So because of the shorter duration of action, it is easy to titrate. Once you stop giving the drug, the blood pressure will come back to normal. So what is the role of beta blockers in the perioperative period? They are cardioprotective benefits, and patients taking beta blockers who suffer myocardial infarction in the perioperative period are likely to survive than those who are not on beta blocker earlier. Patients on established beta blocker should continue. You should not abruptly withdraw because that itself will precipitate a myocardial ischemia. So patients who are on long-term beta blocker therapy should be advised to take the blood drug before surgery and also resume it as soon as possible in the post-operative period. But initiation of the therapy should not be done. Especially some of the vascular surgeons, they advise the patient to take metoprolol just 2 days before surgery. That is not at all correct. If at all you want to start beta blocker to prevent post-operative myocardial ischemia and infarction, it should be started at least 2 weeks before the surgery, especially major vascular surgery, femoropopliteal bypass or aortoilioac aortofemoral bypass. Beta blocker therapy should be started at least 2 weeks prior to surgery. Starting them immediately before the surgery has resulted in more problem than any beneficial. What is the role of alpha blockers in the treatment of hypertension? They are not used as a routine basis, but specific indications are in secondary hypertension, like labetalol for preeclampsia, pentolamine management of pheochromocytoma, and they can be used in benign prostatic hypertrophy, like tamsulosin, which is also an alpha blocker. What is the mode of action of alpha blocker? They are blocking the postganglionic alpha-1 GQ protein coupled receptors, leading to peripheral vasodilatation and reduced SVR. Non-selective alpha blockers. So there are selective and non-selective. They can drugs like pentolamine and phenoxybenzamine, they act on both alpha-1 and alpha-2. So blockade of presynaptic alpha-2 GI protein coupled receptors leads to tachycardia and increased cardiac output. Labetalol is a non-selective beta blocker which also acts on the alpha-1 adrenoreceptor blockade. Carvedilol, which is also used in the treatment of hypertension, has got both alpha and beta. What are the adverse effects of alpha blockers? They can produce orthostatic hypotension, reflex tachycardia, especially after first dose, and they also produce edema, headache, incontinence, and drowsiness. Calcium channel blockers, they mainly act on L-type calcium channels present in the vascular smooth muscle and myocardial and nodal tissues. There are two types which act on the nodal tissues. They reduce the heart rate, the higher affinity for cardiac tissues, they cause negative chronotropy and inotropy. Those with higher affinity for vascular smooth reduced SVR. So they are classified according to the chemical nature as the phenylalkylamine, this verapamil, dihydropyridine is amlodipine and nifedipine, and benzothiazepam is diltiazem. So diltiazem, verapamil, mostly used for as an antiarrhythmic agent rather than antihypertensive. And they are orally administered with extensive first pass metabolism, and IV preparations are available for some drugs like nimodipine and verapamil. Nifedipine sublingually was administered earlier to reduce blood pressure in a faster way, but now not recommended anymore. And their half-life is more than 12 hours. Side effects are reflex tachycardia, potentiate myocardial ischemia. And, disturbance in peripheral microcirculation can lead to swelling of hands. Important complication of the calcium channel blocker, and they can cause ventricular conduction and bradycardia, especially diltiazem and verapamil. They can cause this problem. And cardiac and non-cardiac indications, they are the first line treatment for primary hypertension in people above 55, which we saw. Diltiazem, verapamil are used for tachyarrhythmias and angina. And non-cardiac indications are nimodipine for neurosurgery to reduce cerebral vasospasm. Verapamil is used in neurology to use cluster headaches. And diuretics, they are thiazide diuretics or thiazide-like diuretics, which are most commonly prescribed for treatment of hypertension as a third line of drug. And diuretics used in patients who are intolerant to calcium channel blockers with heart failure and risk or at the risk of used as add-on drugs also. The mechanism of action is they act on the proximal part of the distal convoluted tubule, inhibiting sodium and chloride reabsorption with resultant reduction in water reabsorption. And the thiazides can be attributed to the reduction in antihypertensive effect is due to the reduction in blood volume. They also cause vasodilatation and respond to vascular smooth muscle. One direct mechanism is they can act through the opening of calcium activated potassium channels. Side effects are hypokalemia, hypercalcemia, hyponatremia, all electrolyte disturbance, and hyperglycemia, hyperuricemia, hypercholesterolemia, all those things happen. Plasma volume reduction may lead to dehydration and acute kidney injury in compromised patient. Less common side effects are rashes and photosensitivity. Aldosterone antagonist is a drug which is used as a fourth choice, as I showed in the earlier slide. And loop diuretics like furosemide are also given in resistant hypertension with heart failure. And whether you can continue diuretics, you have to give attention to patient fluid status, and you have to check for metabolic and electrolyte abnormality, because it can cause hyperglycemia, hyperuricemia, all these things. The agents that are used other than these drugs are hydralazine, which is used in hypertension secondary to preeclampsia, and centrally acting drugs like clonidine, methyl dopa, and monoxidine are the drugs that are used. So that completes the discussion on the hypertension and we are going to use. Any questions on that? I think my headphone battery is running down. So if you have any doubts, please ask them quickly. No questions?
Sorry, naloxone AC inhibitor antidotes. Can naloxone can be used as for AC inhibitor antidote as?
AC inhibitors, naloxone. Yes, one answer is correct. Correct. That's the mode of action. Is that is how it is going to use that. Right. So other questions, whatever asked, you just note down. You tell me. Did anyone find out the answer for the last diabetic class question? Why the Roman numerals are not used, and why we are
From
using
the name of the will circle of will that part much. I know particularly you don't know. We'll search it.
The Roman numerals, you know, you write like I1 for one, you put one capital I, for two, you put two I's, and three, you put three I's, like that, no? So somebody read it as type 11 instead of type 2. So people got confused. So they thought there are 11 types of diabetes. So they changed it from Roman numerals to Arabic to make it more easily understandable. There are only 4 types: type 1, type 2, type 3, type 4. So they changed it from Roman to Arabic numerals. That is the reason. Okay.
Okay, sir. Okay, sir.
Right. So if there are no questions, shall we sign off?
Yes, sir.
Were you able to record the class?
Sir, in the class is in auto record mode, sir. It is getting recorded, sir.
So it got recorded. Okay, right. Good night. We will
Thank
see
you,
in the next class. Next class will be comorbidity 3. Obesity will be the discussion. Okay.
Okay,
Okay,
sir.
sir.
So please read about that and we will have a discussion on that. Thank you very much.
Yes, sir.
Thank you, sir.
sir.
Thank you, sir.